Hi everyone, greetings. I'm Izzah, and today I'll talk about an important topic that we often overlook, which is how our medicines use once they leave our neatly organized textbooks. Now, in pharmacoepidemiology, medication usage is rarely clean, it's messy, it's chaotic, it's human, but that's just where the truth lives. So in this particular presentation, I'm going to show you how to make sense of that chaos, okay? Through drug utilization patterns, DUR, GE, ATC, DDD, and also the behavior of the patients themselves. Let's get into it. Drug utilization studies, or DUS, first captured scientific interest in the year 1960s. That's right around when the thalidomide incident happened. Is it a coincidence? Or does it take a whole tragedy for the scientific world to open their eyes towards what truly matters? Well, the WHO describes them as a study of how medicines are marketed, prescribed, and consumed, and the consequences that follow. But for me, the meaning is simpler. The US tells us whether the medicines we believe in are truly being used the way we intend them to be. And unfortunately, the answer is usually no. Here are the objectives to today's presentation. I'm not going to read them one by one. Let's take a look at this bar chart. The usage of medication worldwide is constantly increasing and is forecasted to continue to climb. Need not to say, the more medications we use, the more likely we are of misusing it. This is why the pattern tells stories of access, stories of fear, of trust in the healthcare system, and they reveal what's irrational long before the consequences surfaces. When you zoom out, medication patterns behave almost like social behavior. Some countries take medicines liberally, others cautiously. Globally, use hit 4.5 trillion doses in 2020. But the contrast is striking. 71% of Norwegians take prescription meds regularly, compared to just 23% of Romanians. Besides, medication use is shaped not only by disease, but by income, culture, health literacy, pandemics, insurance structures, and even fear. In Malaysia, COVID-19 didn't just affect infection rates, it reshaped our prescribing landscape. Chronic meds dropped 20%, while antivirals and corticosteroids surged. This brings us to DUR and DUE, two tools that sound technical, but are actually about responsibility. Drug utilization reviews, or DUR, looks broadly at whether medicines are being used safely and sensibly across a large population. Drug utilization evaluations, or DUE, on the other hand, zooms in. It asks, for this drug in this hospital, for this patient population, are we doing the right thing? The answer can be humbling. There are three approaches in doing this. There's prospective, concurrent, and retrospective DUR. Prospective DUR is the proactive one. It happens before a medication reaches the patient, checking for allergies, duplications, interactions, contraindications, and, well, for instance, in Negeri Sembilan, this method revealed prescribing cascades in older adults before the harm occurred. It's prevention at its purest. Meanwhile, concurrent DUR happens while the patient is receiving treatment. It's the moment a pharmacist looks at the current prescriptions and asks, is this still appropriate given what's happening to the patient today? In Sabah, for instance, this approach cut antibiotic consumptions dramatically. Carbapenems dropped 69% and peptides about 44%, simply just because someone reviewed orders within 2.5 days. And then there's retrospective DUR, the reflective one. It looks backwards, studying past charts, identifying patterns, asking what did we miss and how can we prevent it next time. In Kedah, retrospective analysis showed heavy reliance on penicillins and cephalosporins over 2 years, offering insight into stewardship gaps. Personally, I like to think these three forms as a timeline of care, before, during, and after. Together, they create a feedback loop of safety, intelligence, and accountability. The ATC classification system is basically just an indexing system that uses stratified code to let us speak a common language when it comes to medications around the world. For instance, whether it's amlodipine in Malaysia or in Europe, the ATC code is still the same, C08CA01. The WHO already put up an NIPH system which compiles the bibliography of all the ATC codes in the entire world into a single library to facilitate researchers. And then there's DDD, or Defined Daily Dose. It is a deceptively simple numerical system that standardizes what one unit of a specific medication would mean across the world. It lets us compare across hospitals, countries, or decades without worrying about local prescribing habits. For instance, we take a look in the psych ward A in Hospital X. On a particular day, 10 patients have different intake of olanzapine. After brushing up the data, we can see that the total olanzapine use is 80 milligrams per day, but how would we tell this to a country that doesn't use milligrams as a unit of weight? This is where we divide it with 1 DDD unit of olanzapine, which is 10 milligrams, and we get the value of 8 DDDs per day. To make it more relevant for populational studies, we can find the use of olanzapine per 1,000 inhabitants per day. Let's take a look in this ESECnet antimicrobial stewardship case. 29 countries were divided into 2 groups. Group 1 having more favorable AMR pattern and Group 2 having inferior. From this bar chart, you can see that Group 1 use of cephalosporin is definitely much lower than Group 2. One of the countries classified as Group 1 is Greece, meanwhile Group 2 being Netherlands. And take a look at this line chart. You can see how Greece has a spike in K pneumonia and E. coli cases compared to Netherlands, which remains constantly flat. This reflects back to the behavior of cephalosporin consumption between Greece and Netherlands. Yeah, on a side note, you must understand that the irrational use of cephalosporin is the major culprit of resistance of ESBL-producing organisms such as E. coli and K. pneumonia in the first place. This kind of comparison cannot be achieved if we don't have a standardized code for cephalosporins and we don't have standardized units for its use, which is where ETC and TDD comes in. Now we turn to the part of pharmacoepidemiology that is most human: adherence, persistence, and polypharmacy. Polypharmacy is basically the simultaneous use of 5 or more medication. Adherence is to what extent the patient correctly adheres or complies with their regimen regarding the time, dose, and frequency. And persistence is how the patient persists to use the medication up until it's discontinued by the prescriber. Indeed, numbers can't always capture why patients don't take the medicine. Sometimes it's forgetfulness, yes, but sometimes it's side effects, fear, stigma, financial burden, simply exhaustion. Polypharmacy adds another dimension, the mental load of navigating 5 or more medications. A study in type 2 diabetes mellitus showed that major polypharmacy dropped adherence to 66.7% compared to 25.5% in minor polypharmacy. These behaviors don't make patients non-compliant, they make them humans, and they remind us that rational use is not just a prescribing issue, it's a lived experience. Now I want you to take a look at this case on morphine usage in a Serbian referral teaching hospital conducted over a period of 5 years. The drug of concern is NO2AA01, namely morphine, and the unit is expressed in DDD per 100 bits per day. It is a retrospective review. You can see the trend of usage of morphine in this hospital. It is comparatively low compared to the usage in other countries like Spain and Iran. However, the study also found that there is a rise in number of surgical procedures in this Serbian hospital. Now, is the trend of usage of morphine in the Serbian hospital appropriate with the current condition of the patients, or are they underutilizing their morphine resources and letting the patients suffer in pain? Now, let's talk about the pharmacist's roles. This is where pharmacists stand at the very center of everything. We interpret DUR, DUE, we analyze the DDD, we detect the drug-related problems or DRPs, we lead stewardship interventions, we counsel patients, and often we're the last barrier between irrational use and preventable harm. In Spain, in Indonesia, and Saudi Arabia, it doesn't matter, across studies, pharmacist-led interventions consistently reduce DRPs. Be it peptides, glucose-lowering agents, in general, we are the ones who optimize dose and correct prescriptions before it reaches the patients. Take-home point, DUR, DUE, ATC, DDD, they are not just tools, they are ways of seeing patterns, seeing risks, seeing patients, and seeing where the system needs us most. Thank you, and have a good day ahead.